cases which we used for the university examination this time. And similar cases may be, or same cases may be kept for your exam if the situation remains the same. However, if the environment improves, you will be expected to take history, examine, and write a case sheet for a patient with chronic tonsillitis. You can expect that about 40 to 50% of you will be getting a case of chronic tonsillitis. Right, so it's a high likelihood that this will be one of the cases. And the importance, like I mentioned in the theory class, is that you will be asked several aspects. You are expected to know all about this disease. It's a relatively simple disease for which there is medical and surgical treatment available. So you should be aware of the condition, how to diagnose it, and then what are the treatment options available, when to go for surgery, how to manage medically, what are the complications. So all of these points should be known by you. And you should be able to identify the instruments, and there is also an X-ray of the nasopharynx lateral view, soft tissue. All of these are related to tonsillitis. So when you are in a ENT posting in the OPD, what we usually try to do is we allot a case who comes to the OPD with chronic tonsillitis to few of you, and then you will be expected to take the history. Now, history, as you all know, is not history taking is an art. It's an applied art, and it is not very easy. So you will have to elicit the clinical features. Some of the features are evident from when the patient walks into the OPD by just looking at the patient. Some of the features you will get by interacting, by taking the history, and some of the features you will need a specific examination, and then you have to correlate the findings of the examination and history to get into appropriate diagnosis. The ENT case sheet is similar to the case sheets which you are expected to write. You already have classes from other departments. So last time also I asked you to write the case sheet. It is an exercise which all of you must practice. So if you don't know how to write a case sheet, you will get into problems later on. So what I would suggest is I will share this simulated case with you later on, and you can use this clinical features which are shown, important clinical features, and write a case sheet if you have not done so already. All right. So the case sheet will have, as usual, the demographic features such as the name, age, gender, occupation, socioeconomic status, and address in detail. In the simulated case, we have just written Bangalore, but you need to write the full address. Then you go to the chief complaints, basically the reason why the patient has come to the hospital. These have to be elicited from the patient. It is not always something which the patient will tell you outright. Okay, sometimes they will hide the features. For example, a patient with throat pain and fever in the current COVID situation, they will deny the presence of fever. All right. So later on, when you develop the rapport with the patient, and ultimately they realize that they have to be honest with you and they have to give you all the details to get the proper treatment. Then at the end of the session with the patient, end of the consultation, suddenly they may say, "Doctor, mild fever was there since 2 days." So like that, there may be many reasons for patient to withhold information, or sometimes they themselves don't understand what is the question being asked. For example, here in this case, one of the complaint is throat pain. So throat pain can be a vague symptom, though it is very clear to you and me. For the patient, it may be very vague. For example, patient with a itching or a scratchiness in the throat may also call it throat pain. Patient having foreign body sensation in the throat may also call it throat pain. Patient with having difficulty in swallowing may also call it throat pain. But technically, you and me know that throat pain is odynophagia and difficulty in swallowing is dysphagia. And there is a difference between odynophagia and dysphagia. So we know it as medical people, and we need this information to get a better diagnosis and understanding of the patient's condition. So one of the important roles of the physician in the consultation process is to disambiguate and get more information about the patient's chief complaints. So that will be the history of presenting illness, where the chief complaints are broken down, explained in more detail in a standardized format. right? So the case sheet contains demographic features, chief complaints in the order of occurrence, okay, and then you go to the history of presenting illness where the chief complaints are explained. So when you explain the chief complaints, logically you will come to certain conclusions at the end of the history. It's an important history. You will start getting conclusions, and the patient also starts getting conclusions. So the process by which you examine the patient or take the history and you arrive at conclusions or an impression from the behavior and findings of the patient is called transference. The same thing which happens in reverse manner. By giving the history and sitting with the doctor, patient also gains an insight into his illness that is called counter transference. So the clinical encounter or consultation is a complex process of transference and counter-transference. And in this encounter, the physician and the patient don't sit at the same level of understanding or knowledge. The patient is generally expected to have less knowledge and insight than the patient, though sometimes than the physician, though sometimes it is opposite. All right, and the physician is expected to have greater knowledge and experience than the patient when it comes to disease. So there is a lot of subtle interactions and changes which occur in the consultation process, which we are unable to simulate. However, in the case of tonsillitis, we have certain important complaints. One of them is throat pain. Pain, again, when you're taking the history of pain for any patient, the pain can be of different types. Can you tell me the types of pain? I want the answer in the chat box. Different types of pain. Yes, are students still there or they're all sleeping? Please answer in the chat box. What are the different types of pain? Pricking type. Pricking type. What else? Dull aching pain. Very good. Stabbing pain. Referred pain is not a nature of pain. It is a special category. So somebody mentions referred pain. We'll come back to that. Colicky pain. Very good, but not applicable to throat. It is mainly for hollow organs, viscous organs of the abdomen. Throbbing pain, very good. Any other types of pain? Spasmodic, again, it is colicky pain. It's a different pain which is found in hollow viscous organs. Flank pain is a location. Location of pain here, it is very clear. It is throat pain. Pulsating pain, somebody mentioned previously throbbing pain. So it's another word for throbbing pain. What type of pain do you experience when you put your hand in hot water? So people are very interested in general surgery. All of them are in colicky pain, spasmodic pain, or squeezing pain. Burning pain, very good. So you can get burning pain. So in the throat, we generally get a dull pain or a burning pain or a throbbing pain. These are the three types of pain I would expect in a case of tonsillitis, right? Sharp pain can occur when the sharp pain or stabbing pain can occur when there are ulcers formed on the surface of the tonsil and when the patient tries to swallow. Somebody mentioned the referred pain. So basically referred pain is a type of pain where the primary pathology is at a site which is distant to the region where pain is present. For example, patient may have pain in the ear, but the pathology may be in the throat. In a patient with tonsillitis, there may be ear pain. Patient may complain of ear pain. Okay, so pain is a very important complaint. Okay, enough of visceral pain. You can please discuss that in general surgery, not for ENT, right? So the throat pain can be of different types, and it varies according to the type of infection, the pathology which is occurring on the surface of the tonsil, as well as it is modified by several factors. Pain can be affected by the patient's mental condition as well. Some people are very stoic. That means they will not accept the presence of pain very easily. Whereas some patients are very sensitive, and even a mild discomfort, they complain very loudly, saying very severe pain. However, whenever there is a enlarged tonsil like shown in the picture with surface ulceration, I would expect a significant degree of pain. Pain is generally measured by use of pain measuring scale. That is, there is a pain scale, there is a visual analog scale. Basically, 0 to 10 scoring, and 0 is no pain, 10 is the most severe pain which is imaginable. So the patient scores that, and then we look for the change in the pain scoring as the patient improves or deteriorates at the course of the illness. So when you are writing a case sheet for an inpatient who is having an acute exacerbation of tonsillitis when you are doing your internship, you are expected to monitor the pain by using a pain visual analog score. All right. Okay, that is about throat pain. Throat pain. So one more complaint which can occur in a patient with tonsillitis is the foreign body sensation or obstruction to swallowing. This is called as dysphagia because of the physically enlarged tonsil. So in this picture here, you are seeing the tonsils are quite enlarged. So we can grade the enlargement of tonsils into grade 1, 2, 3, 4. Basically, how do you size it? You have to divide the tonsillar size into 4. Okay, 0 to 25% enlargement, 25 to 50% enlargement, 50 to 75% enlargement, and 75 to 100% enlargement. So you keep the midline as the maximum enlargement of the tonsils. The tonsil can enlarge till the midline because both sides, if they enlarge and reach the midline, then they are grade 4 or kissing tonsils. Okay, both the tonsils touch each other in the midline. At the other extreme, we have grade 1 or tonsils which are so small that they cannot be seen clearly because they lie within the tonsillar fossa. That means the tonsil has not come out of the tonsillar fossa. The tonsillar fossa is bounded medially by the free margin of the anterior and posterior pillars, plane formed by the anterior and posterior pillars. Okay, so we now define the two extremes, grade 1 and grade 4. So what are grade 2 and grade 3? Grade 2 means the tonsil has come out of the fossa. Okay, the fossa is bounded by the plane formed by the anterior and posterior pillars, but it has not crossed the midpoint between the tonsillar fossa and the midline. So there is a midpoint. You can mark the midpoint between the tonsillar fossa and the midline, and it has not crossed that midpoint. So this is grade 2. Grade 3 is it has crossed that midpoint, but it has not yet gone to the midline. So very easy grading of tonsillar hypertrophy 1, 2, 3, 4. This is an important way in which we can classify the tonsillar hypertrophy. Why did I come to that? So because we were discussing odynophagia, in cases of grade 3 or grade 4 tonsillar hypertrophy, where the tonsils are significantly enlarged, then what happens is the patient can have a physical obstruction to the passage of food through the oropharynx. So that is presented as odynophagia. And that is one of the important indications sometimes for the, considering a surgery. For example, in this same child, 6 years old, if the child is constantly losing weight and underweight for age, that one of the reasons may be the obstruction sensation which is caused by the enlarged tonsil, and that will be one of the good indications for doing surgery. Okay, so the entire history taking and examination is done with a goal of giving relief to the patient, right? So if the patient is having a significant problem or a complication caused by the pathology, then we have to give relief to the patient with our measures, either non-medical measures, medical measures, or surgical measures. So the entire goal of this is that, and to do that, you have to come to a proper diagnosis. So that's why we discuss so many things. I will not discuss the complaint of fever in detail. It will be discussed more in detail in your general medicine and pediatrics classes. However, it will suffice to say that in tonsillitis, acute exacerbations of chronic tonsillitis, the fever will be high grade and lasting usually a few days, 2 to 3 days, and then it subsides with the tonsillitis, right? Okay. In this such cases, what would be the significant negative history? Okay. Can you think of any significant negative history you want to ask when you encounter such a patient in the OPD? You can type your answer in the chat box. Waiting for your answers. Nasal obstruction, very good. Asthma, okay. So Kavita, why do you want to ask for asthma? Can you justify? Nasal obstruction I accept because when there is tonsillitis, there can be adenoid hypertrophy, which obstructs the nasopharynx, like I mentioned in the theory class, okay, and that will lead to nasal obstruction. Why? But why asthma? I agree that it can be asked. You can ask for a negative history of asthma, but why? Okay, Vaishnavi says ear pain. Monisha says snoring. Yes. Gambhir says hearing loss. Yes. Hearing loss, in this case, I will expect a conductive hearing loss because of Eustache and tube obstruction, and uh, there will be fluid collection in the ear. Halitosis, yes, because of chronic infection, there can be foul smell in the breath. So that can also be one of the complaints which we can ask a negative history about. So asthma, since, okay, if a patient is having asthma, okay, they are already having a compromised lower airway. The respiratory compromise can be exacerbated by a collapse in the upper airway, which is caused by obstruction. So one reason can be there is a apnea, sleep apnea occurring, which is exacerbating the lower respiratory problem. Second reason can be that the inflammatory mediators within the upper airway can affect the lower airway and worsen the asthma also. Okay, that can be the other reason why you ask for history of asthma. But see, the exam, if you're writing a case sheet and you ask for any negative history, you should be able to justify why you asked for it. It should not be something blindly you are asking for a negative history. Cough. Yes, there can be cough when there is inflammation of the upper airway. There can be a reflex cough because of the irritation. Sore throat is again another word for pain in the throat. Yes. Fever, already there is a history of it. So you should ask the relevant negative history. In a person who is having similar history in the past, multiple episodes in the past, there is a possibility of bacterial infection with Streptococcus. Streptococcus, like we discussed in the theory class, it can have systemic implications, right? What diseases you suspect or systemic complications you want to rule out when you are examining such a patient. Systemic breathing difficulty is not a systemic complication, it's a symptom. So I mentioned Streptococcus. If there is streptococcal tonsillitis, yes, rheumatic fever, rheumatic heart disease, and acute glomerulonephritis. These are some of the common complaints. Toxic shock syndrome is rare in our country for some reason. So we have to take the history and examine the other systems as well. Okay, so you have to even investigate the other systems. That will be dealt in detail in your medicine and pediatrics classes. But when we come to investigations, I will tell you more in detail. So once you do that, you take the history, then you go for examination. Again, general physical examination, you will be learning more in the other classes. Then we go to ENT specific examination. First thing is examination of the oral cavity and oropharynx. For this, you need a light source. Generally, we use a headlight, which is placed in the middle of the examiner's forehead, which gives a parallel beam of light. Otherwise, you can use a head mirror, which you will place on the examiner's eye. There will be a light source behind the patient's shoulder. The head mirror reflects the light, and then the examiner uses the head mirror to see. Then the instrument used for examination is the lax tongue depressor. Okay, it is, you will be seeing this in the instrument class and also when you come to the OPD. So the patient is asked to open the mouth. And then we have to give the instruction that the patient has to breathe slowly through the mouth, in and out. No, don't hold the breath. And while breathing through the mouth, keep the tongue loose. You will use the tip of the tongue depressor to gently depress the tongue and then examine the oropharynx. But you may use a second tongue depressor to elicit the characteristic sign, okay, which is known as Irving-Moore sign. We discussed it in the theory class, right? Okay. So we also discussed in today morning's class. So I will not go into the same details again. After examining the oral cavity, you saw that there was a high arched palate and crowded teeth, which are shown in the picture, right? And there is an enlarged tonsil, grade 3 tonsillar hypertrophy. The tonsils are inflamed. an examination of the neck, possibly there will be a tender enlarged tubulodigastric lymph node. You also have to examine the nose. In this case, I would expect a reduced airflow because of adenoid facies, which is one of the findings in the picture, right? So there will be a nasal obstruction and reduced airflow. And when I have to examine the ear, if there is obstruction of the eustachian tube, you will see a dull-looking tympanic membrane with loss of cone of light or distorted cone of light, and there will be for sometimes air fluid level or bubbles behind the tympanic membrane. After all this examination, you document the findings in the case sheet, and then you go to the diagnosis. The diagnosis will be, in this case, acute exacerbation of recurrent adenotonsillitis. So you look at the past history of similar complaints in the past, acute exacerbation of recurrent adenotonsillitis. Okay, that is the diagnosis which I'm going to come in this case. So suppose the throat pain is there for long period of time. Okay, here throat pain is only 3 days. Suppose they say throat pain it is there since 2 months, then I will say it is a chronic tonsillitis. Whereas here it is only 3 days, but the history of some complaints is there since 1 year. So I will name it as a acute exacerbation of chronic adenotonsillitis. Any doubts with the history taking, clinical findings in a case of adenotonsillitis or diagnosis? It has been discussed in the morning as well. That's why I'm going fast in this section. Do you have any doubts? I'll just take down this picture. I want to show you some slides. So in the meanwhile, any doubts you can ask me in the chat box or unmute yourself and ask.
Excuse me, sir.
Yes.
So why is it adenotonsillitis and not just tonsillitis?
See, you look at the picture, there is a second picture below. The second picture shows a high arched palate, crowded teeth, protruding incisors. These are characteristic features of adenoid facies. Like I discussed in the class previously, adenoid facies is a constellation of signs which are seen in a patient with adenoid hypertrophy. It occurs because of nasal obstruction and constant mouth breathing, which leads to the maldevelopment of the midface. So since there are signs of adenoid hypertrophy also, it will be adenotonsillitis.
Okay, sir.
Any other doubts? Okay, so once you come to your diagnosis, next will be investigations. Investigations have multiple roles. Okay, one of the roles of investigation is to confirm your diagnosis and to expand your diagnosis. Second role will be to find out whether there are any complications and then prepare the patient for treatment. Okay, and also to give the prognosis. These are the roles of the investigations. Investigations, when they are asked in the exam, you should always mention the specific investigations, right? The specific investigations for a case of adenotonsillitis. First will be throat swab for bacterial culture and sensitivity. Second investigation will be for adenoid hypertrophy confirmation. Either I will do a X-ray nasopharynx lateral view soft tissue exposure. So when they ask you, you should mention this entire thing. X-ray of the nasopharynx. Adenoid is in the roof and posterior wall of nasopharynx. That is the region. So you have to say X-ray of the nasopharynx, right? Soft tissue exposure because you want to look at the soft tissue of the nasopharynx, right? X-ray of the nasopharynx, soft tissue exposure, lateral view, not anteroposterior, only lateral view of the nasopharynx. Okay, so this is the investigation of choice in children. In adults or older children, you can also diagnose adenoid hypertrophy by doing diagnostic nasal endoscopy. Okay, trying to share a presentation. It's not coming up. Just give me a second. Okay, so apart from that, what other specific investigation I will do to rule out the complications of tonsillitis? We will need to we will need to do investigations for the kidney and heart. For the kidney, we do urine routine to look for albuminuria or proteinuria. We can do serum creatinine. And then for the heart, we can do a echocardiogram if you're suspecting rheumatic heart disease. Blood culture can be done if you're suspecting severe infection or possibility of streptococcal septicemia. So these are some of the investigations. Apart from that, one of the older investigation is ASLO titer to confirm the presence of streptococcal bacterial infection. So these are some of the investigations which you can do in this case. Nowadays, there are also some investigations which can be done to confirm the presence of streptococcal infection. Okay, it's loading. So there are rapid bacterial assessment tests. After this, you come for the treatment. Treatment will be initially medical to reduce the infection and then surgical. In the previous class, I shared with you the conventional tonsillectomy, cold steel tonsillectomy by dissection and snare method. Today, I am going to share with you the use of one instrument which is known as coablation assisted surgery. So first will be endoscopic assisted coablation adenoidectomy. It's a short video. So just look at the video. I hope it plays.
The coablator-assisted adenoidectomy is a simple and clean procedure wherein the adenoid is excised in toto under direct vision using the coablator wand, the EVAC 70. At the very start, the palate is pulled forward with the help of a red rubber catheter, and the entire adenoid with whatever is visible of the posterior septum is visualized. Now the wand is introduced and coablation is initiated starting from the lower border of the adenoid mass. The wand is used to detach the adenoid mass from its attachment, and the whole adenoid is removed in toto. Bleeding points that are visualized can be cauterized using the same wand. At the end of the procedure, the entire length of the posterior end of the septum is clearly visualized.
So in that video, you saw endoscopic assisted coablation adenoidectomy. You could see the posterior end of the nasal cavity, that is the choanae, the two choanae, and also the posterior end of the septum. The endoscope, for your orientation, was placed in the oral cavity. It's an angled endoscope, and you can see the nasopharynx using the endoscope, and under direct visualization, the surgeon used an instrument called coablator, which generates a sodium plasma field, and that sodium plasma field is used to resect the adenoid. So similar surgery which is done, I'm going to show you in this video. Here the surgeon is using the coablation wand to remove the tonsil. You can see the uvula in the midline. The coablation wand has suction as well as continuous dripping of saline. And then there's an electrical arc which is produced, which splits the saline into plasma. So this plasma is at a low temperature, around 40 to 45 degrees. And it's a low temperature resection of the tissue, right? So it's an instrument, that's all. The technique itself is very similar to the cold steel dissection technique. Why do they use this instrument? Basically, as you are seeing, it is a relatively bloodless surgery, less amount of blood loss, but it needs little more experience and there is a learning curve for the surgeon. And the instrument uses that wand. That black instrument you're seeing is actually a disposable part of the instrument, and that is little expensive. Okay. One of the concerns with this technique was increased risk of secondary hemorrhage, slightly increased risk of secondary hemorrhage. Advantage will be that there will be less post-operative pain and less bleeding intraoperative. So this is one of the newer technologies which is used for adenotonsillectomy. We have this equipment available in our hospital. Okay, so we do use it whenever the patient needs it or when they are affordable for the equipment. Video isn't playing. Okay, I can see the video playing on my screen. So what I will do is I will share the PPT. Anyway, it's on a PPT. I will share the PPT and you will be able to play the video and just watch yourself later on. Okay. Let me see if I can share it right now. I'll share the link to the slides. Okay, I have shared the link to the video in the chat box. Those who are not able to see the video can open it separately and view. Okay, I will also post it on Teams. So basically, I wanted to show you this because in the exam nowadays, there are many of the examiners expect you to know the newer technologies which are available, and also not only in the exam, when you pass out, you should not be unaware of these things which we are having and doing in our college. Also, we are having and doing these things, so you should not be unaware of these things, right? Um, in the future, possibly, if there are good conditions for healthcare, we may be doing these type of surgeries with latest equipment more and more, right? But always the gold standard is the cold steel dissection and snare method because of easy accessibility, low cost, and lesser complication rates. But we do use new equipment. Laser doesn't have any role in uh, tonsillectomy. Are there any doubts? Do you have any doubts? I will take the attendance now. So if anyone has any doubt in the meanwhile, you can ask me. Likith has raised his hand. Likith, tell me what is the issue. Any doubts?